Okay, so welcome everybody. My name is Alex Labrinis. I'm a professor of computer science here at Pitt, in case you don't know me. I'm the Colloquium coordinator for this year. I'm very happy to welcome you to our first computer science colloquium of the season. And I will pass on the microphone to Dr. Jake Bill to introduce our speaker today.
Yeah, so just before we get started, just for the benefit of our speaker, which I'll introduce in just a second, I think it's always good when I'm speaking, especially in an academic setting, to know who's in the audience. So how many are PhD students in CS or ISP? Yeah. How many people are first, second, or third year PhD students? How many people are fourth and higher PhD students? So younger crowd, we're establishing this. How many people are doing work in AI or computer vision? How many people want to know more about AI and computer vision and its application in this? Good, so an attentive audience.
You did not ask about undergraduate students.
Oh, how many undergrads do we have in this?
At least one.
2, 3, 4. Oh, excellent. This is great. Okay. So it's my pleasure to have Ahmad Tafti, Professor Tafti here, visiting. Well, I guess you're like me. You're kind of in two places, right?
Yeah.
So you're faculty in the Intelligent Systems program here at the School of Computing, but also your main appointment is in the School of Health and Rehabilitation Sciences in a really interesting department called, let's see here, Health Information Management. So you guys do, this is the Department of Health Informatics, essentially.
Exactly, yeah.
So over there, Dr. Tafti leads the PEX, or the Pitt HEX AI Research Laboratory, which is conducting research at the intersection of health and explainable AI. He also has a health explainable AI podcast series, which I've listened to some. It's really great. In addition to his academic appointments, he is also appointed at the UPMC Pullman Cancer Center, and he is also the vice chair of the IEEE Computer Society Pittsburgh chapter, which is exciting. I need to know more about that. Ahmed is one of us. He is a PhD in computer science, bachelor's, master's, and PhD.
So
he's, one of us. So I'm really excited because I want to know more about image segmentation and particularly identification of anatomy related to a grant proposal that we're working on together. So without further ado.
Thank you, Jake.
Yep.
Yeah, thank you. Hello, everybody, and thank you for coming to the talk, and thank you, Jake, for, first of all, to organize this kind of seminar series, and also thank you for your nice introduction and also having me in this seminar series. As Jake really mentioned, my name is Ahmad Tafti. I am coming to you from the School of Health and Rehabilitation Sciences. I am actually leading Pitt HEX AI Research Laboratory, and HEX AI stands for Health and Explainable AI, in which we are actually developing, building, validating AI components, and mainly explainable, accountable, and interpretable AI components in clinical settings. One of the clinical settings we are really interested in is actually total joint arthroplasty. And what I mean by total joint arthroplasty is actually knee replacement, shoulder replacement, and hip replacement with the use of AI and advanced computational strategies. And the data source we are mainly utilizing is actually medical images, including X-ray images, CT images, and MRI images. So I'm also conducting like a HEX AI podcast series, and podcast series is publicly and freely available to our community. And let's begin my presentation. First of all, I declare I have no competing interest. So agenda of my today talk is actually I will first start with medical image segmentation in orthopedic setting. Then I will start my talk with problem statement to highlight the problem statement in hip and knee bony anatomy segmentation and why we are going to do unbiased kind of segmentation, why this is important, and what we mean by that. Then you will see objective of this project, and we will review together materials and methods, including data source, and how we can make and how we built actually fully annotated imaging data set. We will be slightly talking about deep learning method or deep learning methods we used in this kind of work, and we talk about bias mitigation strategy, And I will finish my talk with some sort of experimental validation and demonstrate some sort of results or promising results, and also discussion and outlook. So let me show you this.
My name is Kurt Weiss. I'm an associate professor at the University of Pittsburgh, where I am a musculoskeletal oncology surgeon scientist. I work in the Department of Orthopedic Surgery and in the UPMC Hillman Cancer Center. Segmentation is something that we use routinely in orthopedic surgery, but where fairness becomes very important is when we're looking at anatomical differences between, for example, the male and female pelvis. When I'm operating on cancer of the pelvis, the male pelvis is shaped more like a cone, and it is very, very challenging to operate on in terms of cancer. Whereas the female pelvis is more open, it's more bowl-shaped, and that makes it a little bit easier. So these sorts of differences are what we're trying to get at with our study of fairness and segmentation.
Thank you. So with that, let's start talking about problem statement. So I guess whatever Dr. Kurt Weiss mentioned to you, it actually highlighted the fact that image segmentation is important in orthosurgery, but also unbiased image segmentation is more important. And there is a list of disparities and differences among anatomy, among like different race, different gender, and things like that. So let's start with problem statement. So problem statement is this. So we all know that AI and particularly deep learning strategies have already demonstrated very successful application in a variety of medical image analysis tasks, including 3D reconstruction, object localization, image classification, and image segmentation. And all of these, they do have very high demand application in ortho, particularly for hip and knee bony anatomy segmentation. And if we want to talk about hip and knee bony anatomy specifically, so they do have application in preoperative and postoperative setting. What we mean by preoperative setting, imagine, for example, a surgeon, they want to have patient in the surgery room and do some sort of surgery. So the hip and knee bony anatomy segmentation will help them to gain some sort of knowledge and insight and fact before doing surgery. And for postoperative assessment, we can account for something like physical therapy, recovery, those kind of things, and also avoid to have any infection or complication after surgery. So with all of that, this is the problem, or this is the question. So question in computer vision, question in medical image analysis, as question in utilizing AI to tackle the problem within this setting is actually how to uncover and address potential biases within this setting. So with that, our project objective, or at least within this project, we have several objectives. So the first objective of this project was actually to develop, build, train, automated, and also validated automated image segmentation system that fits very well in knee and hip bony anatomy segmentation using only plain radiographs or using only X-ray images. So the second objective was actually to assemble or to computationally assemble fully annotated knee-hip image segmentation dataset and make that image dataset publicly and also freely available to our research community for open scientific research. So, and the third objective was actually to uncover and also mitigate or reduce some sort of biases or visible biases related to gender and also racial groups within this work. So let's have a quick review of clinical significance. So when we talk about any research project, you all know better than me that we need to talk about technical significance and also clinical significance. So you guys as computer scientists, we all know about technical significance, but let's focus on the clinical significance at the moment. So this, such a system, as also Dr. Kerr truly mentioned, so is actually objectively promoting equitable and also inclusive healthcare provision. So for different population, for different genders, for different race, and also it helps to come up with accurate diagnosis, accurate prognosis, an accurate treatment strategy for diverse patient population, and potentially this kind of activity or this kind of research projects will lead to better clinical outcome. So with that, let's start with material and methods. So the very first thing I need to talk in material and methods, I will start with the data set. So the data set we used to build fully annotation data set, and also with the data set we used to train and validate deep learning strategies. So there is a freely and publicly available data set called Osteoarthritis Initiative provided by NIH. So this data set is available to all of us. You just need to create an account and get that data set. There is about 4,000 different patients, or the cohort include about 4,000 patients, all suffering from knee and hip osteoarthritis. And the data set includes tons of images, including X-ray images, CT images, and MRI images. So, and it has been around the community for many years. So we actually computationally assembled a retrospective cohort from Osteoarthritis Initiative dataset. So our cohort within this project was actually 766 patients for hip and 707 patients for knee. And we utilized X-ray image, and the cohort was like one hip or one knee at least for one of those patients. So, and in total, this kind of investigation resulted in a total of 1,473 plain radiographs. So the next item I would like to talk after dataset is actually image annotation or manual image annotation, and how we actually were able to build fully annotated imaging dataset within our group. So the very first thing to start is actually reliable data. So we as computer scientists, when we talk about data, we all know that quantity of the data is very important, particularly when we are talking about deep learning strategies. We all know that those strategies, they are data-hungry mechanisms. And regardless of few shot, meta learning, those kind of things, we need high quantity data. But from other side, we as computer scientists also know that quality of the data is very important, right? When we want to get some sort of medical images, and those medical images are tied to radiology report, are tied to clinical notes, the quality of those radiology report is very important to us, right? Level of agreement among radiologists. So the gold standard data there is very important to us. So with all of that OAI, I can tell you, based on my previous experience, I have been working about, it's now about 5 years I am working in ortho setting. So OAI dataset is a very nice, feasible, and handy, and very high qualitative, quantitative dataset to use. So the data you will see there is very high standard. So the very first thing, we need to talk about reliable data, and we need to consider reliable data in our data acquisition. And we assume that, so that data we already had. So the next thing, we call it annotation guideline. So we have to, we are working in hip and knee bony anatomy segmentation, right? So our surgeons are actually qualified, or they are only person who can develop, who can build, who can draft annotation guidelines to us, right? So we actually had surgeons within our team to draft annotation guidelines. But of course, we cannot account for our surgeons to do manual annotation, right? They are pretty much busy, and their time is very expensive, and we want to have them to mainly focus on value-added surgery, right? Not just annotating data. That means we need to have MDS students, we need to have other, folks to do the data annotation, but for sure, based on the annotation guideline provided by the surgeon. So within our pipeline, you can see that we had annotation guideline provided by surgeon, but we also had trained annotators. So within this work, we had 3 annotators, and those annotators, they actually utilize ITK-SNAP, which is a widely used segmentation toolset for medical image analysis, for medical image segmentation. And this is an example you can see, like a manual segmentation utilizing ITK-SNAP with one of our annotators. So, and as you can see here, this kind of like step number 2 and step number 3 is actually iterative process. What I mean is that, for example, among 3 annotators, we need to find, we need to see, and we need to get to a certain level of quality among annotators. What I mean by quality is inter-rater agreement, right? To make sure that all 3 annotators, they are doing good job, right? So if they did, then we didn't need to revise, we didn't need to change or make comprehensive annotation guideline. But otherwise, we need and we did that, right? So for training annotators, we actually started with first 100 images, like same 100 images. We call it first batch among 3 annotators. So in which we can calculate intersection over union, or we can calculate inter-rater agreement. Without same images, we cannot, right? But after that, to speed up the project, and we continuously check and make sure that we keep same level of inter-rater, promising level of inter-rater agreement. And after that, we feed our annotators with different images. So once after that, we have tagging evaluation among annotators, and also having a tag like an evaluation for the final round. And for image segmentation, I don't know how much you are familiar with image segmentation. So I have seen there is a list of folks doing computer vision. One of the criteria, one of the metrics we are using in image segmentation, we call it IOU, in intersection over union, in which we want to see the area of overlap and also area of union, right? So imagine, for example, I as annotator number 1, I am annotating patella like this, right? But you as annotator number 2, you are using this kind of shape, like a bigger kind of shape. That means the intersection union among you and me is not that much good, right? So we need to come up with a nice intersection over union, and the excellent or nice, it's a mathematical metrics. So above 89, we can call it excellent intersection over union, and we achieve that. From technical side also, you can see that this segmentation was not that much challenging segmentation task from computer vision perspective, right? So the main aim here was actually to tackle the problem of unbiased segmentation. So with all of that, let's talk about materials and methods, like continue talking about material and methods. And this time, we have gold standard data, right? We have fully annotated imaging data set within HIP and within knee setting, and we want to develop classification tasks, segmentation tasks to objectively and automatically segment any plain knee or hip radiographs moving forward, right? So before I continue with deep learning strategy, I want to have you focus on this image, right? So we all know that this is image segmentation, in which we are going to segment different bony anatomies. But from computational perspective, we can turn any segmentation task into a classification task. What I'm trying to say is actually pixel-wise classification, right? So like, for example, pixel you can see in femur, we can classify it in a class number 1 or class green, right? Left patella class red or something like that. So what I'm trying to say is this. So it's even segmentation task, we can turn it into pixel-wise classification. With all of that, within deep learning strategy, we first of all, we actually utilize UNet, which is a very famous, popular, and widely used deep neural network architecture appropriate for image segmentation. And you perhaps know UNet will receive original image with fully annotated, with fully, kind of manual segmentation, and do some sort of downsampling and upsampling to find meaningful features, to extract many meaningful features, including some sort of edges, binary objects, those kind of things, and combine them with the corner, and come up with the segmentation, right? So instead of only utilizing UNet, we actually incorporated UNet with the ResNet to have UNet extract those kind of meaningful features for us, and then use ResNet to do the classification task. And we actually achieved nicer performance in comparison to only UNet. So now with all of that, let's start talking about baseline model and mainly talk about bias, or bias there is in the data, the bias we have in the data, and also how we can mitigate bias, and what kind of strategies we use to mitigate the bias. So first of all, let's start with the baseline. So we actually had all of our data, we call it combined groups, including all race, all genders we have. In a one same group, we call it baseline model. So whenever we use that kind of data and split that kind of data into and train and test, we call it baseline model, because we didn't split that kind of data in terms of gender, in terms of race, right? So the next strategy, we call it balanced data set, in which we try to undersample the overrepresented protected group. So when we talk about our data, you saw that, so there is a 700 in he, 700 in hip. So moving forward, you will see further information. The data set is somehow unbalanced in terms of male, female, in terms of different race also, or different racial groups. So when you will see in quantitative and quality analysis, if you see balanced data set, that means this is the kind of training we use, right? So we undersample the overrepresented predicted group in training data. This approach actually aims to mitigate risk of model exhibiting bias towards the majority group, like white versus African American. So the third strategy, we call it stratified batching, in which we actually utilize mini batch with a specific kind of unbiased distribution of samples or instances we have. So this approach groups samples based on the protected attributes and randomly sample instances from each group. So, and we all know that in deep learning strategies, one of the parameters we have is called mini batch. So this process we use in training phase, and we call it stratified batching. So moving forward, when you see a stratified batching in that qualitative, quantitative tables, that means this kind of a strategy. So and last one, we call it group specific. So one group was male, one group was female, one group was white, one group was African American, and those kind of people. So we actually made our data set based on those different groups, and we call it group specific model to mitigate bias and improve overall fairness. And we will see the result, right? So at this moment, we are not sure which one will work and which will outperform the other strategy, but moving forward, we will see. So let's talk about experimental setup. So moving forward, starting from this slide, you will see list of experimental validation or experimental study utilizing four different mechanisms to see how we were able to, or how we are able to mitigate the bias. So first of all, experimental setup. So whatever experimental validation you can see here, we actually use data science service at Oracle Cloud Infrastructure, equipped with NVIDIA V100 GPU and 16 gigabyte memory to tackle this kind of problem. So, and for training and validation and testing, we use PyTorch 1.13.1 and also Python 3.10.11. To ensure to receive high performance, high validation accuracy, we actually employed and investigated different hyperparameters within those deep learning strategies. And we ended up with like a 50 epoch with a batch of 16. And for optimization, we used Adam optimizer with a learning rate of 0.005. And as we discussed already, for metrics to make sure that we are doing good job in terms of segmentation, we use intersection over union. For those who are familiar with DICE, who are familiar with image segmentation, you may ask why you didn't use DICE score. So the answer is going to be DICE score based on our experience is actually working well when the segment size is not that much big. But in this kind of images, so the size of the segment is big. So we actually turn our gaze into intersection over union rather than DICE score. So in terms of fairness evaluation, to evaluate fairness of our model, we actually utilize very well-known popular SER, focusing on specifically evaluating potential bias in the algorithm, prediction error towards a specific group, and this is SER, maximum, for example, y minus IOU of the predicted group, divided by minimum, 1 minus IOU. So if you want to replace it with Dice score, good to go, and it's reasonable. So, and as you see here, SER is actually utilized ratio of highest to lowest error rate among protected groups. So, and there is a definition, there is a description here within our research activity. So if SER is actually higher value of SER present higher percent of bias, while lower level are of SER and somehow SER close to 1, it actually indicates like a kind of reduced bias or no bias. So let's start experimental validation and results. First of all, in this table, you can see the distribution of the cohort we had. So in terms of gender and in terms of the race, like gender including male and female. These are actually two genders we can see in that OAI dataset. So, and also race, they call it white or Caucasian, and also black and African American. So, and you can see male, female, number of patients, so the percentage within hip bony anatomy setting and within knee bony anatomy setting. And to provide you with a better understanding, so this is the pie chart illustrating or demonstrating distribution of hip patient and distribution of knee patient. And as you can see, so majority of our cohort is actually white. And so we move on. Okay, so in table 2, you can see, or in this slide, you can see group IOU or racial group intersection over union versus fairness score. But this slide is demonstrating hip segmentation. So the results you will see here is all about hip segmentation. So as we discuss about bias mitigation strategy, you remember that we had a model called baseline, combining all cohorts, right? So balance undersampling the overrepresented group. So stratify batching, in which we used mini batch with the same distribution of each protected group we had, and also group specific. So the interesting thing we can see in this table is actually intersection over union, or there is a trade-off. I would say in summary, there is a trade-off here, right? So intersection over union, we got better intersection over union when we actually use combined cohort, right? So when we actually down to group specific and also stratify batching, you can see that intersection over union decreased. Not that much significantly, or but it actually decreased, right? However, the SER, like the bias, like the reduction of the bias, is getting better when we start from baseline all the way down to group specific, right? So what I'm trying to say is actually this, right? So there is a trade-off between these two things. You can see while we can achieve higher IOU, right? So, but we are not that much doing good in terms of SER, right? So, or we are doing good in terms of SEI, but we are not good in terms of IOU, right? When we are getting better and better in terms of IOU, but then SER is not that much good, at least within this kind of setting. And you can see same for black and African American people. So let's look at gender or a gender specific kind of analysis. Yes, there is a question.
I did not follow. Why should there be a trade-off between bias and performance?
So here, so I will talk at the last minute of the presentation. Here is the experimental results we can see. So our investigation is showing like the baseline. In baseline, we are receiving better intersection over union, right? Among white, among black people, in terms of the segmentation task, only in terms of the segmentation, right? But in terms of bias, you can see that SER, which one is the smaller? This guy is the smaller, right? A smaller SER come from group specific. Better IOU come from baseline, like the combined.
The experiment result shows that you have better performance. I mean, the trade-off can be seen, but I was trying to understand why there should be a trade-off.
Oh, why should be trade-off?
Yeah. So, for example, the model could, like intuitively, the model could perform well in general for all cases, and thereby mitigating bias. So you should not have any biases in the model.
Well, we should have, and we had the bias, right? So beginning of my presentation, I showed you like a kind of talk provided by Dr. Kurt Weiss. He's an orthosurgeon. He's working with us. We are, close collaborators, right? So, and as he talks, so there is a big difference between the hip shape among female and male, right?
Yes.
Yeah. So that is one thing I can tell you at the moment, right? So, and when I am saying there is a trade-off, it means that if we want to achieve, in this problem setting, my friend, there is two metrics. One metric is intersection over union, just to make sure accuracy of the segmentation task, regardless of bias, no bias, those kind of things, right? There is another metric called SER that demonstrate any level of bias, and like how we can make a fair AI model, okay? So when I'm saying trade-off, with the combined group, we are enhancing or we are increasing level of IOU, but our result, our experimental validation demonstrate that we are actually losing some sort of fairness in the AI model, right? And nowadays, accuracy is not only important thing, right? So we also want to make safe AI model, fair AI model, unbiased AI model, and also explainable AI model, right? Otherwise, we cannot use and implement those kind of AI models, at least in clinical setting. So the next one, the first one, it was about gender group distribution. Oh, yeah, the first one is about racial group. So the next one is about gender group. So you can see again baseline analysis or baseline mitigation strategy, balance, stratify group specific. You can see IOU among male, IOU among female, and SER among all of these like a data set. And again, you can see scientific visualization with the baseline male, baseline female, balanced male, balanced female, stratify male and stratify female, and also group specific, similar like that. And you can see again, this kind of pattern happens here as well. So let's go to table number 4. In table number 4, we are doing same kind of analysis starting from racial group with knee, and then go with like a gender group with knee. So here you can also see that, so intersection over union, we have better intersection over among the baseline, but here also SER is getting better when we considering knee. And I will have something to show you at the very last slides, why we are seeing this kind of differences, at least from our orthosurgeon's point of view. So, and this is the scientific visualization to see the trade-off, to show the trade-off among IOU and also SER, intersection over union and SER. So let's look at the racial, like a gender group, the comparison between intersection over union and also intersection over union among female and male, and also SER among different, strategy we used. And you can see the result. So to conclude and to make a summary, we can, among all of those scientific visualization and all of those experimental validation, takeaway would be group-specific modeling, as you have seen, emerge as the preferred option for hip segmentation, not that much for knee segmentation. But it even ranks second for knee segmentation in terms of the fairness. So when we actually discuss this kind of results, in which we achieve these results computationally, right, and experimentally using our data set, when we discuss this kind of things with our surgeons, these results actually did make sense to them. So what we were told was that, so the hip, when we are saying group-specific modeling emerged preferred option for hip, there is a reason. As the beginning of the slide, right, there is a big difference between the shape of hip among different genders, among different racial groups, right? But for knee anatomy is similar between male and female, right? Knee anatomy is also similar among different racial groups, right? But perhaps the size of the knee is gonna be different based on the level of fat in the body, right? The weight of the body or age of the body, right? So, and here in this study, we didn't incorporate age, right? We just used racial group and we just used like a gender group. So the second takeaway is actually a stratified model or models. They actually demonstrate remarkable effectiveness in mitigating racial bias in knee segmentation, achieving nearly perfect result. So, and this is only for training purposes. It works for training purposes. And the selection, the other one is selection of an approach. Whether it be baseline, this is actually our summary. Imagine you want to use baseline, you want to use balance strategy, you want to use stratify batching, or you want to use group specific. These kind of mechanisms, if you want to choose one, two, or combine them together, is actually guided by the specific segmentation task. You need to look at your segmentation task. What I'm trying to say is that, at least based on our experiment and our study, we don't have that much consistent strategy to say, okay, we can stick with that and do this in all segmentation tasks in medical image analysis. So the answer is no, right? So we need to think about a specific segmentation task, and we need to have anatomy involved, like if you want to do knee, if you want to do brain, if you want to do hip, and those kind of things. And also nature of bias is also important to us. So with all of that, I would like to acknowledge many people in our group without whom that work was not possible. So first of all, I would like to acknowledge our orthosurgeons, Dr. Johannes Pelate, and also Dr. Kurt Weiss. They are at UPMC and also the Shady Hospitals. They are in University of Pittsburgh orthosurgery department. I would also like to thank Dr. Ines Lohse. So he's also in ortho surgery department, but he's doing cancer biology. Dr. Amirian from University of Georgia, she does have expertise in AI and deep learning mechanisms. So Nicholas Littlefield is actually my PhD, my new PhD students, University of Pittsburgh. Ismail, my master's students here, University of Pittsburgh. Zui is doing undergraduate study in health informatics within our program. Mernaz is also doing master's study in health informatics program within our group, and Luke Carson is MD students at University of Pittsburgh School of Medicine. So, and these are the recent publications we had. So within these kind of activities, we published a paper called Enforcing Explainable Deep View Shot Learning to Analyze Plain Knee Radiographs, Data from Osteoarthritis Initiative. The other one was Learning Eye-Biased Image Segmentation, Case Study with Plain Knee Radiographs. And the other one, AI Fairness in Hip Bony Anatomy Segmentation, Analyzing and Mitigating Gender and Racial Bias in Plain Radiography Analysis. For those who are interested to learn more about my PTEX-AI Research Laboratory, I would highly encourage you to use this QR code. So this will help you to get to my research laboratory called, again, PTEX-AI. You will see our research activities, you will see our opening position, you will see our research papers and things like that. And also, if you are interested to learn about our podcast series, so the other one will help you to get there. So with all of that, thank you so much. And this is my email address. Please feel free to reach out to me for collaboration. And I would love to have collaboration with you guys. And with all of that, again, thank you, Jake. Thank you, Computer Science School of Computing and Information. Thank you, all of you. And I would be happy to take any questions you may have. Thank you. Yes, please. Yeah.
So, your fairness metric, are there other fairness metrics that you would maybe recommend in this scenario, or some sort of combined metric between the accuracy and fairness? Because if the performance for both groups goes down, even if that's more fair by this metric, that's still not good.
Yeah, you are right. So actually there is actually open research at the moment, like the fairness analysis and safe AI is a open research at the moment. So people doing different stuff actually. So I have seen some couple papers, they use very traditional statistical strategy like a standard deviation to look at the fairness, but to me it was basically about the robustness of the model, not that much about the fairness. So the only thing we have at the moment, at least my group, is SER, but moving forward we will learn more and we will incorporate more statistical mathematical strategies to tackle the fairness in our model. And you had a question, I guess, right?
I'll let the student
Yeah,
first
sure.
go.
Actually, while annotation, you used this ITK snap.
Mm-hmm.
So that is acting as a seed for the annotators. So
Mhm.
what was the, like, say, biasness can come from this model itself, like as you're giving the seed to annotators, so they can just say that, yeah, it is correct, even like.
What do you mean by seed?
So seed as a, when you're trying to annotate a segmentation, instead of doing it everything from zero, you are giving them some kind of start earlier with this data set. So with this model, so a bias can come from this model as well.
You are saying bias may come also from annotators,
Yeah.
right? So I would say you have something to add here.
Or the tool that you used. I think
The
that's
tool
more
which we are
for
using.
ITK Snap. Is there bias from ITK Snap potentially?
So here is the thing. So ITK Snap have been around for many years in the community of medical image segmentation, right? So many people, many researchers, many work you can see, they use ITK Snap. So it's a very popular image segmentation tool set or manual image segmentation tool set, right? Within our pipeline, we actually try to come up with a high standard mechanism, right? So we had, within this work, so we had an iterative process to organize annotation guideline with our surgeons, right? We started with version 1 and we ended with version 6, right? So each time they had different question, and the story is not all about inter-rater agreement among annotators, right? It's also about how they can use ITK Snap, how they can use different mechanisms. For example, the first time they used mouse to annotate with polygon to annotate those images, and then we find out so they can also use pen, and the pen is more accurate. But after all, they saw that no, pen is not accurate, similar like mouse. Then we switched to the mouse and used that polygon, right? And when they were actually doing data annotation or image annotation, at the first batch, at least, as I told you, it was 100, we had our surgeons, we had our physicians to be with them, right? To make sure that they are doing great job. So from other perspective, we actually developed some sort of another tool set to enhance the contrast of the images. For example, if you look at the raw plane radiographs of knee, patella is not that much clear in that image, right? We need to do some sort of pre-processing step, data normalization, data harmonization, right? To make the images visible to all annotators. So it was some sort of iterative strategy, but we did our level best to make sure that we are coming with a very gold standard annotated data set.
Thank
You're welcome. Yes, please.
So, like at the end of your explanation, you showed that some of the outcomes, they showed still favoritism or a bias, right? So, already existing research exists in the field of utilizing PRISMA, the preferred reported items for systematic meta-analysis, and the usage of PubMed libraries for taking help of surgeons where they can actually rule out the bias by giving their medical insights instead of just using explainable AI. So is your team would your team in the future, or is it considering involving more and more surgeons to give their human inputs to rule out the bias and then probably utilize AI so that the bias is not there?
It's very, very, very nice question. Very great question, right? But so my experience is this, right? So this is a very nice question from technical point of view, right? But when you want to do it, when you want to go through the uptake and implementation, particularly in clinical setting, it's gonna be very daunting task. So I can tell you something, right? So, and just between us, right? So even in one hospital, I promise, I saw that, I have seen that for many times, not only one time, right? Even in one hospital, you are working with two surgeons. Doesn't matter, they are orthosurgeons, they are neurosurgeons, whatever, right? Or whoever. So I have seen, like in the same group, same hospital, one orthosurgeon, he or she does not share data to the other one, right? He said they were my patients. If you make AI model with this, you cannot share the model itself, regardless of the data. Data is another story, right? Data, of course, they don't want, right? What I'm trying to say is this. So we have very good kind of things, right? So very good kind of initiatives to share, to put, and to have them up and running. But in practice is another story. You know what I mean? So they don't listen to you. They don't listen to me. And you want to change it, you want to turn it into real practice, they will say, oh, this AI will take my job, will take this, will take that. How about HIPAA? How about patient privacy? How about regularity frameworks? So many scary stuff will come, right, and hurt you, right? So that's the thing. Yes, from research perspective, it's very nice if we can do it, but implementation, very daunting task. Yeah. Next question. Yes, please. Sorry.
It's more like about the use case. So from what I understood, it's more like in a surgical setting, right? It's to have like an image before you open up the knee or the hip, and you pretty much know what you're like dealing with. But you also mentioned at the beginning that you were working with MRI images. Like from my experience, I've been injured a couple of times, but from X-rays, like you don't get much information.
That's true. That's true. That's very true.
Have you done like similar work with MRI? Because I'm thinking like muscle, like you have a lot of bias like in muscle tissues as well, and not just like bone.
Yeah, there is a short answer to your question and longer answer. Short answer, this is ongoing kind of work within our group, within my group, to utilize MRI. But from clinical perspective, you perhaps know that. So when you see an orthosurgeon, they will normally start with X-ray image, because it's very cost effective for the patient, for insurance companies, for healthcare providers. They don't say do MRI at the beginning, right? So this is the pipeline. We want to start with the X-ray, but for sure we are having MRI, we are having CT and those kind of things in the loop, right? So you had a question, please.
Yeah, like about intra-class variation. Does that influence a lot about like fairness evaluation? Because you said you segregated by gender and ratio groups, but then you have like also a multitude of individuals in those groups, right?
Mm-hmm.
If those groups they overlap too much, or they are like kind of segregated already, does that like influence that much?
We didn't investigate that one yet. Yeah, we will, but at this moment, I won't have something to share with you. Yeah, to be honest with you. Yeah. So yes, please.
The fundamental question.
Yes, please.
Okay, so the goal, as I see it, is to create the system which will segment the best without biasing towards particular group.
Mm-hmm.
Right? It
Yes.
looks at that image and it segments the
Yes.
best possible without biasing to particular group. However, it's absolutely not clear to me why do we need that, because we will know
Mm-hmm.
which group it is. Why not to use it as an additional feature for classification? Why not to work with this knowledge?
With what? Why not to work with what?
Not to add race and gender and weight as additional feature to classifier, to make the best possible prediction, because those things are known. Like I would think that would make sense if we work for something which we don't know these features, right? And we want to get rid of bias. But in this case, we want this bias because it helps us to diagnose.
So are you saying,
Yes.
let's say, for example, for a patient, we have his, her race, we have his, her age, we have his, her ethnicity, why we are not incorporating those kind of data into our predictive descriptive model? Is this your question? So I would say, so for many cases in clinical setting, so again, if we talk about research and we talk about real world scenario, they are different things, right? In real world scenario, when you go and look at the EHR, electronic health records, there is a tons of missing values there. So for example, you have information, you have image of the patient, but in electronic health record, you can find ethnicity, you can find race. The patient themselves, they didn't declare ethnicity. They said unknown. They said, I don't want to declare. You know what I mean? Even for gender. Meaning that in some cases, we don't have access to that attributes to incorporate them into the model. So here we wanted to develop AI algorithms that can only look at the plain radiographs, just images, right? And then do the task automatically and objectively, right? Did I answer your question? Any, yes, please.
I think as a follow-up to this, you can see like the next paper, which would be one that says if we had that information, then that's how it would benefit the most.
There is a lot to
like
do.
The gender, for example, almost always you know. The race, probably you don't. And if the more complicated thing, maybe you don't either, right? But that would be kind of the next, like if you start combining information and see what's the benefit.
Very good insight, but as we already discussed in this room, so we all have seen that there is a list of avenues to go, right? So one guy is truly suggesting MRI, because MRI representing more accurate, in-depth kind of information inside from the image, right? So you are suggesting this lady is suggesting that, right? There is a list of research avenues, and it means, you know, we need tons of hands, right? To have this kind of initiatives, activity up and running. Yeah.
I do have another question.
Please.
So the data from the NIH, do they include only healthy patients or only patients that?
They do have case and control, both of them. Yeah.
So it's not just people that have problems with their needs.
So I would say they had, right? But if you look at there is also Excel sheet. For example, if you look at the Excel sheet, you can see for a list of the patients, KL grade, which stands for level of osteoarthritis, is not that big, right? For example, 0, right? Or level of pain, like 0, between 0 and 10. Yeah, that means to our clinician, that means healthy people, they think that they have or they had pain, but it was not that much pain, or not that much clinically meaningful pain.
And they're all snapshots, like it's one-off. It's not like over years, like following patients over years.
They do.
They do.
It's the beauty side of this data set is actually longitudinal data. Yeah, they have, for example, like a 60 months kind of follow-up. Yeah, follow-up. Yeah, within each patient. Thank you, guys. Thank you so much, and I will be with you after this, so please feel free to reach out to me. And you have my email address, so Tafti, here it is, tafti.ahmadptdu. Yeah, it's easy to find me. Yeah.
Thank you.
Thank you, Jake.
Thank
yeah.
you.
Thank you so much. Thank you, guys. Thank you. Thank you so much. Thank you so much.